All right, let's dive in. You shared a source with us, this very specific medical document,
Yeah.
a post-operative protocol from Dr. Gregory Weir, a vascular surgeon. It's all about patient care right after a femoral-popliteal bypass.
That's right, a fem-pop
So
bypass.
our mission here is to kind of cut through the clinical jargon,
Uh,
and really get to the core of what's absolutely critical in those first hours and days.
mhm.
Turn this dense protocol into something clear for you, the listener. Looking at it, what immediately jumps out?
Well, it's a great snapshot of standardized clinical practice. A fem-pop bypass, it's major surgery, rerouting blood flow in the leg around a blockage using a graft.
Right.
And success really hinges on that immediate post-op care. So protocols like this, they just provide a clear roadmap for the team. Very important.
Okay, let's unpack that first big thing the protocol zeroes in on.
Yeah.
Managing blood pressure. Specifically keeping the mean arterial pressure, the MAP,
Hmm.
really tightly controlled between 70 and 100 mmHg. Why is hitting that specific target so critical for the new graft?
Yeah, that's absolutely crucial. The new graft is just incredibly sensitive. You need enough pressure, that 70 minimum, to make sure blood is flowing strongly through it, pushing past any resistance, preventing clotting.
Okay.
But if it's too high, say over 100, you risk stressing those fresh surgical connections.
Yeah.
That could cause bleeding or, well, damage. So that range, it's all about maintaining just the right flow. Not too little, not too much.
The protocol gets really specific on what to do if you're outside that range. If MAP goes over 100, it says titrate nitrosine.
Right.
But if it's below 70, it gets a bit more complex. You check the central venous pressure, the CVP, first.
Exactly.
And it says if MAP is low and the CVP is less than 10 centimeter H2O, then you give a Ringer's bolus. But if MAP is low and CVP is over 10, then it's noradrenaline titration. Why the difference?
Well, this is really smart guidance. It's basing the action on why the pressure might be low. CVP gives us a clue about the patient's fluid volume, their sort of tank level.
So if MAP is low and CVP is low, the likely issue is they just don't have enough fluid volume. The tank's low. So Ringer's standard IV fluid helps fill that tank up.
Right, brings the pressure up.
Yeah. But if MAP is low and CVP is not low, meaning they seem to have enough fluid on board, the problem isn't volume. It might be the blood vessels are too relaxed, too dilated.
I see.
In that case, you need noradrenaline, that's a vasopressor. It constricts the vessels, tightens things up to raise the pressure and help flow through that graft. It's about treating the underlying cause, you see.
Got it. So diagnosing the why before jumping in, that makes sense.
Yeah.
Now, beyond blood pressure, there are other general care points listed. An O2 mask, elevating the leg if there's swelling,
Oh, edema. Yeah.
keeping hematocrit, HGT, above 30%, and getting a chest x-ray to confirm the CVP line placement. How significant are these sort of simpler steps?
Oh, they're fundamental, but absolutely essential. Oxygen obviously ensures tissues get what they need. Elevating the limb helps reduce that edema, the swelling, which is key because too much swelling can actually compress the graft itself.
Ah, right. Impeding flow.
Exactly. And keeping HTT above 30% ensures the blood isn't too thin, has enough red cells to carry oxygen, and supports, healthy flow viscosity through the new bypass.
And the x-ray.
Just confirms the CVP line, which we need for those pressure readings, and maybe giving meds like noradrenaline is safely in the right place. Standard safety check.
Okay. Then there are the lab tests, timed out pretty clearly. Day 0, HT and TROP-T. Day 1 adds UKE, FBC, CRP, myoglobin, and TROP-T again. What are these tracking so soon after surgery?
Yeah, they're watching the immediate response. HT confirms that blood thickness target we mentioned. TROP-T and myoglobin, they can indicate if the heart muscle or other muscles faced any stress or minor injury during the operation.
Okay.
UKE tracks electrolytes. FBC gives the overall blood picture, watching for loss, infection signs, and CRP monitors inflammation, important for spotting infection or any big reaction around that graft.
And finally, diet and moving the patient.
Yeah.
Day 0, they can eat and drink, but strict bed rest.
Yep.
Day 1, start gradual mobilization. Seems quick, but also cautious.
It is. Allowing diet early gives fuel for healing. But that strict bed rest initially, absolutely non-negotiable. The fresh graft connection is fragile, needs protecting.
Right. No stress on it.
Then day 1, starting to move gradually, carefully. That's the beginning of recovery. Getting circulation going again, but very safely, without risking the surgery site.
Okay, so we've walked through this protocol's detailed blood pressure plan, tying MAP and CVP to specific actions, covered the essential support care elevation, HTT, the lab monitoring timeline, and that initial eat but don't move, then slowly mobilize plan. It really lays out the immediate game plan from this source.
Exactly. And what this kind of protocol really underscores is the precise layered approach needed right after this kind of surgery. These specific steps you've pulled from the source, they form a direct clinical strategy. It's all designed to protect that vital bypass graft, stabilize the patient in those critical first, say, 48 hours, standardizes the care.
Yeah, understanding these specifics, the pressure numbers, the CVP logic, when labs are drawn, when they can start moving, gives you, the listener, a really sharp picture of that immediate post-op phase this document describes.
It does, but it also makes you think, doesn't it? This is a standard protocol. How may individual patient factors, like maybe other health problems they have, or even just their age, how might those things subtly change or, well, complicate this recovery journey in real life?
Yeah.
Things not spelled out here.
That's a really good point.
And maybe what other monitoring becomes really crucial after these first 48 hours that the protocol focuses on? What comes next?
Yeah, a great question to ponder. What happens beyond this initial snapshot? Well, thank you for bringing this source material for our deep dive today. Really fascinating stuff. Keep that curiosity going.